Good morning, everyone. Today we'll be having a look at two cases. Case one is a 65-year-old woman who had come with headache for 8 days. Her MRI revealed an intraaxial thick peripheral rim enhancing lesion with central non-enhancing necrotic part measuring 2 into 1.5 into 1.9 centimeters seen in the left middle frontal lobe. The T2 weighted and FLAIR images revealed heterogeneous hypointense mass and moderate white matter edema was noted. Now, case 2 is a 50-year-old man who presented with giddiness. The MRI findings revealed multiple well-defined nodular enhancing lesions involving right parieto-occipital lobe. The largest lesion measured about 2.7 into 1.6 centimeters. The T2 weighted and FLAIR images revealed hypointense lesion and the T1 was isointense. Now this is what we received in our lab, and the lesion was whitish and showed areas of necrosis. For the case one, we had to do intraoperative squash cytology. So you can see this lesion is a necrotic lesion, and on the background you can see these slipper-shaped or elongated epithelioid cells. You can see an ill-formed, granuloma here, and this here is a multinucleated Langerhans giant cell. The histopathology was very typical, and we saw extensive foci of caseation necrosis. There were well-formed granulomas composed of epithelioid cells, Langerhans giant cells, and lymphoplasmacytic infiltrate with macrophages. Perivascular infiltration by lymphocytes and plasma cells was noted, and the peripheral tissue, brain tissue, showed reactive diosis. So this is the typical histopathology, the multinucleated Langerhans giant cells. These are the granulomas, and this is the caseation necrosis. So coming to the discussion part, the most common clinical presentation is pulmonary tuberculosis, and whenever it affects the CNS, its manifestations are more aggressive. The intracranial manifestations can be in form of diffuse meningitis, tuberculoma, tuberculous abscess, focal cerebritis, vasculitis, and stroke. The predisposing factors is mainly immunosuppression due to HIV, diabetes mellitus, malnutrition, chronic renal failure, cancer, the patients who are on immunosuppressive or chemotherapeutic drugs. Basically, one must remember any comorbidity can predispose a person to tuberculosis. Now, this tubercle bacilli comes through hematogenous dissemination from an extracranial source to the brain. This M. tubercle bacilli is capable of crossing the blood-brain barrier as a free, that is extracellular organism, or via monocytes and neutrophils. Once the bacilli have reached the brain, several cytokines, tumor necrosis factor alpha, interleukin 1 and 6 are produced by macrophages, microglia, astrocytes that increase the permeability of the endothelial cells penetrating the blood-brain barrier. Now, the two scientists, Rich and McCordock, described that cerebral TB develops in two steps. Initially, small tuberculous lesions known as Rich foci, they tend to coalesce and enlarge during the stage of bacteremia. These tubercles can produce caseation necrosis, epithelioid cells, lymphocytic infiltrations, and the Langerhans giant cells. The rich foci can rupture and develop into several types of CNS tuberculosis, leading to meningitis. They may rupture into the subarachnoid space or into the ventricular system. The serious complication of chronic tuberculous meningitis are arachnoid fibrosis that causes arterial occlusion and brain infarcts. Spinal cord and subarachnoid space, when it gets involved, the cranial nerve roots get affected. Now, tuberculoma, it mainly presents as a space-occupying lesion in the brain parenchyma, and on imaging, it may mimic like a glioma. So this tuberculoma may manifest as subacute or chronic illness lasting from weeks to months with predominance in the immunocompromised patients. When the lesion is isolated or small in size, the clinical course may be asymptomatic. Larger lesions may be multiple, and these patients may present with fever, vomiting, headache, focal neurological deficits, seizures, hydrocephalus, meningeal irritation signs, and raised ICT with papilledema. In patients with HIVs, these tuberculomas may cavitate and fill the cavity with fluids which turn into abscesses. And these abscesses may go through the intervertebral foramina leading to paraplegia. On imaging, the mimics of tuberculoma are glioblastoma, brain metastasis, intracranial hemorrhages, abscesses, and the gliomas, other gliomas which may be associated with calcification that produce the target sign. This is suggestive of reactivation or a dormant tuberculosis. Now, on CT scans, these lesions appear hypodense or isodense masses on non-contrast studies, but after contrast administration, they show ring or homogeneous disc-like enhancement with an inner region of hypodensity. Now, MRI is considered slightly superior to the CT scan because one may come to know the size and the number of the lesion, and it also helps to identify the caseation necrosis. Now, imaging of the caseating tuberculoma are generally composed of three zones. The inner zone, which is made up of caseation necrosis, it is typically isointense or hypointense on T1 and T2 respectively, and the middle layer presents with hypointense or hypointense signals due to presence of Langhans cells, epithelioid cells, and edema in T1 and T2 respectively. And the external layer, it is a collagenous or the fibrous capsule layer which appears as iso or hypointense on T1 and T2 weighted images. Now coming to diagnosis, whenever a sole tuberculoma is present, then the CSF analysis may be normal. Whenever tuberculous meningitis is present, the CSF has typical cobweb-like appearance may be present. On cytology, there is moderate lymphocytic pleocytosis. However, sometimes a mixture of additional neutrophils may be present. The protein levels are markedly elevated and the sugar levels may be low or normal. Now, 20% Zeal-Nelson staining, ZN stain for the acid-fast bacilli must be carried out. The sensitivity is 70% and specificity is 97%. One may get then CSF ADA levels. It is usually found raised in TB. However, one must know that raised ADA levels may be found in patients with lymphomas, malaria, brucellosis, pyogenic meningitis, and other lesions. The culture of CSF for M tuberculosis is negative in the tuberculoma. So one may go ahead with the PCR test, that is molecular analysis. Now, PCR can be done by CBNAT, that is cartridge-based nucleic acid amplification test. Now, the gene expert assay, it has line probe assay 1 and 2. The line probe A1, that is, it helps not only in detection of the bacilli, but also one comes to know the primary drug resistance, that is rifampicin or INH. And in the LIPA2, one may get a knowledge about secondary line of drug resistance involving aminoglycosides and fluoroquinolones. The drawback of this test is one cannot detect a typical mycobacterium. And if the test is readily available, then the turnaround time is 3 to 4 hours. Now, this is a technology called as matrix associated laser desorption ionization time of flight mass spectrometry, that is called as MALDI-TOF MS. One can detect any species based on this methodology. It is very cost effective, but the drawback is one needs to have a growth for this method. Acid fast bacilli culture and sensitivity remains the gold standard. But one thing is the TAT for this is almost 2 to 2.5 months. So one may have get done the gene expert test, which may on that basis they may start the empirical treatment. And of course, this tuberculosis is curable with anti-tuberculous drugs. Thank you very much.